You are watching your award-winning cable access station, Channel 13 and 19, Athol Orange Community Television.
Welcome to Quabbin Valley Health Links. I'm Michael Cacciadorian. Today's show is about hospice, and joining us to talk about this topic is Debbie Tischler, Community Liaison for Brookhaven Hospice. Welcome to the program.
Thank you.
I think hospice is a topic that people don't know a lot about, or they have a sense of what it is, and it may not be entirely accurate. So I thought this program would be good to elaborate on hospice, demystify hospice, explain to people exactly what hospice is, so that they can make a more informed choice about their health care as they need to. So let's just get to the basic. What is hospice and what does it do, so to speak?
Really, hospice is just a special way of caring for someone with a terminal illness. It's a team-focused approach. The focus is on managing symptoms rather than managing the disease. The focus is on comfort, emotional well-being, quality of life, and most important, hospice tends to focus on the whole family, not just the patient.
That's a good point. I think people don't understand the scope of resources behind hospice and what's available to the family. We'll get into that later. What do you mean by the team? What does a hospice team consist of for a patient and their family?
The hospice team is a number of different disciplines that are all available to the patient or their family if they wish. The registered nurse case manager is sort of the leader. He or she is the one that sees the patient first, does the initial assessment, does the initial plan of care. The nurse case manager visits weekly, continually assessing, monitoring, treating symptoms, and providing overall support and education to the family that's caring for their loved one.
Okay.
And we have a social worker. And the social worker is available for any number of things, really. The emotional challenges of dealing with someone or having a terminal illness. Social worker is available for help with advanced planning, legal issues. Social worker can help the family locate resources in the community that might be helpful for them. Generally, when a person is first admitted to hospice, a social worker will meet with the patient and the family, and together they can decide how the social worker could be most helpful.
I see.
Every team has a chaplain. The chaplain is a non-denominational, available to visit people of all faiths and answer questions of a spiritual nature. They're dealing with fear, anger, loss. Chaplains available to talk about forgiveness. Chaplains also available to help the family or the patient find local clergy, rabbis, priests in their own community that could come visit. The home health aide, very important because the families tend to get closest to the home health aide because that's who they see the most. The home health aide provides personal care under the direction of the case manager and overall companionship. Sometimes it's something as simple as sitting with the patient to give the family a break, reading a book. In the nursing home, the home health aide is available as an adjunct to the nursing home aide staff to do some of the things that sometimes the nursing home staff doesn't have time for. Taking the patient outside for a walk on a nice day, things like that.
Sure. How about do you have a base of volunteers that you utilize?
Yes.
Okay.
Volunteering is a very big part of hospice. And we are always looking for volunteers. Our newest office is here in Gardner, so we're definitely looking for volunteers in the Quabbin Valley area.
So you essentially just opened up your new space a few months ago in Gardner.
Yes.
You've been servicing this community for the greater Quabbin community for a while now.
A long time, yeah.
So you are definitely looking for more to ramp up your volunteer
Absolutely.
services. Okay. What does a volunteer do, and would a volunteer have to go through any specific specialty training to be a volunteer with Brookhaven or any hospice?
The volunteers are really just caring people in the community that want to give something back. Sometimes it's students. And they can really be helpful in a number of ways. There's a very intense orientation program that they go through. They're constantly getting staff education and supervision. I think for the volunteers would say that it's very rewarding for them.
I'm sure it is. And I'm sure it's rewarding for the patient and the family, too.
Absolutely.
Absolutely. So, end of life is a scary phrase, I think, for a lot of people to grasp, and I understand that. I had personal experience with it. And what does it exactly mean, though, as it relates to hospice? Is there a defined end-of-life period in order to qualify for hospice? If you can just explain that so people have a better understanding.
In order to qualify for hospice, someone has to have been diagnosed with a terminal illness with a prognosis of 6 months or less.
Okay.
That being said, nobody has a crystal ball, so
Yes.
6 months is really a guideline of sorts. Something to think about when the curative treatment, the aggressive treatment, is no longer effective. That's the time that maybe bring in hospice. The patient wants to change from that aggressive treatment
Sure.
to comfort measures, quality of life.
Who makes the decision or the conclusion that somebody may have 6 months or less to live? Is that
Their primary
care
physician. Yes.
Based on whatever types of experiences they've had along the way in terms of their treatment. So if I'm watching and I'm caring for a family member who was just diagnosed with a terminal illness, but may not have a 6-month diagnosis yet, or 6-month time frame yet, or I'm the person themselves that was just diagnosed, or caring for somebody that is, who and when should I discuss hospice? You know, when does that topic come up? When should I start talking to my family or my caregivers about that?
First of all, I think in the hospice community, to us, end of life is really just another phase of life.
Okay, right.
And ideally, we should all be discussing with our own families as early as possible what we want for ourselves should we have a serious illness. Likewise, you should be discussing that with your doctor as early as possible. It's really about having control over your own choices while we still can,
Yes.
and making sure that should something happen, there's no guesswork. Everybody knows what we want. Do we want CPR? Do we want to be defibrillated? Do we want to be intubated? Do we want to live on a respirator? So advanced directives, being very clear with the people that would be involved with you.
Okay. So if I wanted to bring hospice into the home or call a hospice agency, can I do that anytime? At
You
least
can
for
do
some
that
advice and
anytime.
understanding of what to expect?
Absolutely. If you're thinking about hospice for yourself or a family member or a patient, you can call a hospice office anytime and we can set up an informational interview.
Okay.
And, just allay some of your fears.
Right. Well, I think you made a good point that it's about what came to my mind was being empowered while you still have that opportunity to do so and have this resource to help you through that process. Me included, I think a lot of people think hospice, cancer. And it tends to skew that way, but it's not always the primary diagnosis or not even part of the diagnosis. So aside from, explain that. I know cancer is probably a primary diagnosis of some sort, but there are other issues and other diseases people have, and you manage those or you work with all types of terminal illness. Can you talk about that?
Well, unfortunately, cancer does continue to be the number one hospice diagnosis. However, very common hospice diagnoses: end-stage cardiac disease, congestive heart failure, end-stage pulmonary disease, Alzheimer's dementia, all very common.
I don't think people necessarily view someone with Alzheimer's dementia, do they qualify for hospice? But it's all about this terminal path that somebody is.
Because it's a vascular
facing.
disease, yeah.
Pain management must be a big component of what you do, but I know you describe it differently. And I think patients who are on hospice expect that part of this hospice program is pain management, that they're going to be relieved from pain. But I think you've expressed it as more of a symptomatic or a symptom treatment. Can you? Symptom
management.
Okay.
And for some people, pain is the most uncomfortable symptom. For other people, shortness of breath. People with end-stage lung disease, shortness of breath might be their primary symptom. Nausea could be a primary symptom. Oftentimes you see incredible weight loss patients, and once the nausea is treated and their symptoms are managed, oftentimes you see these people start to thrive a little bit and put on weight. So any symptom that is of concern to the patient is what we would manage.
So would using the term sort of a holistic approach be appropriate?
Okay.
I think there's a misperception of hospice care in terms of it being a 24-hour-a-day, 7-day-a-week on-site visit by somebody from a hospice organization is providing direct hands-on care, but that's not necessarily true. Explain that. When does hospice come in? How often are they in? And who is really the primary caregiver and when somebody elects to be on hospice?
Okay. There is no setting in which hospice is the primary caregiver. In the home setting, the family and the significant others continue to be the primary caretakers, with visits by the case manager, constantly monitoring, reassessing, reevaluating number of visits, ongoing support. The hospice team meets every 14 days as a team. Again, always reevaluating. The other thing is with all the players on the hospice team, someone might be there every other day, every day. You know, that we try and stagger our visits. You don't want the nurse and the social worker there on the same day. So,
But as people's conditions progress and they're soon to pass away, do services at that point get ramped up a little bit, or is it really just individualized based on
everything's individualized? There is no
needs?
cookie cutter hospice plan for sure. Everyone's hospice plan is individual. So, you know, again, between the case manager and your own personal physician, who is still very involved with your care and still signs off on any changes in your care plan, and under the direction of our medical director as well.
So they're working together.
Absolutely.
So you don't lose your primary care physician.
Not at all.
The patient's primary care physician, your medical director, they're working with each other.
And the case manager is in constant communication with your own doctor.
So people don't have to fear that their primary care is no longer involved.
They're very much involved. In the nursing home setting, the nursing home staff continues to be the primary caregivers. Their nurses, their nursing aides, and we're an adjunct to that.
So essentially it's the same thing as being at home.
Correct.
Except at a place like Quabbin Valley, our staff, when there's a hospice patient, our staff is essentially doing what a family member would do.
Correct.
But because we have 24-hour-a-day, 7-day-a-week care, it seems like, you know, there's maybe more hands-on care. Because we have that staff, but you're still coming in exactly as you would in somebody's home if they lived at home.
And one of the things that we do at Brookhaven Hospice is we have what we call monthly collaboration meetings with the nursing home staff at Quabbin Valley or wherever, whatever nursing home we happen to have patients in. It's a monthly meeting. Your staff gets together with our staff, exchange ideas, keep the lines of communication open, make sure everybody has a matching care plan for the patient. We're all on the same page. Sometimes it's about sharing stories and
Absolutely. So now the big question, I guess, is how is all this paid for? And that being in the healthcare arena as well, you know, I've seen a lot of confusion and who's paying for what insurance company pays for it, and so talk about that if you can. Who is paying for hospice?
Okay.
Whether it's at home or wherever, how does that get paid for?
Okay. Hospice is a benefit of Medicare.
Okay.
Most, if not all, state Medicaid programs also have a hospice benefit. All private insurers should have a hospice benefit. However, when it comes to commercial insurance, I would strongly recommend that you call your own insurance company and find out the specifics on their hospice coverage.
Okay, so you mean commercial, anyone on an insurance plan that's not
Not Medicare,
Okay.
not federal, not state.
Okay,
In the nursing home setting, hospice bills Medicare for payment. Hospice does not cover room and board.
so the patient and the family is still responsible to pay the daily room rate?
Correct.
Unless they have a Medicaid?
Medicaid backup
right.
or private pay.
Okay. So in the nursing home, Medicare will pay for the hospice services, and then the patient, and if they're enrolled in Medicaid, that covers the room and board for the
Correct.
nursing facility, or the family pays the private, or the patient and the family pay the private room rate.
Correct.
I'm at home. What's the cost? It's just covered by
Medicare.
Medicare.
And you pay your own room and board like you pay your rent or your mortgage.
Okay, so, yeah.
Which is why
of course.
hospice doesn't pay room and board in the nursing
That's right.
facility, because they consider it your home, really.
Right. So hospice has a respite benefit associated with it, and that respite benefit, from my understanding, is I may have been caring for a loved one who was terminally ill for 3 months on a 24-hour a day, 7-day-a-week basis, and I need some rest myself.
You need a
that
break.
I can continue
Yes, you do.
providing that care. That person, the patient who's on hospice, could actually come to a facility, a skilled nursing facility, for a period of time.
Correct.
And that is covered.
That is covered, yes.
For that defined period of time.
Yes, there's no
for
extra
your-
room and board on that.
That's right. But it also allows perhaps even the caregiver to just get their own affairs in order
Yes.
and kind of regroup
Yes.
and then bring that person back home and continue caring for them.
Correct.
Which I think is a great benefit.
It is a great benefit.
I think, again, people aren't aware of that type of benefit being available to them.
And I think that the hospice staff can also help the family to realize you do need a break. It's okay. You don't have to feel guilty.
Right.
You're entitled to a rest.
When, the reality is the patient's going to pass away, whatever time frame that is, then there's a grieving process the family is going through. You, meaning hospice in general, you just don't walk away.
No, not at all.
You continue to provide a set of services to the family, the
Yes.
grieving family and loved ones. What is that, and if you can explain what those services are?
Grieving, the bereavement of a family is probably one of the most vital parts of hospice. Brookhaven Hospice has a bereavement program. We follow a patient's family or their loved ones for 13 months following the death of a loved one, probably more if necessary. By following them, I mean letters, phone calls, support groups, visits. In the nursing home setting, Brookhaven holds a memorial service twice a year for the families who have lost patients in the nursing home. And also for the staff, too, because the nursing home staff becomes incredibly
Yes,
attached to these
they do.
patients. So the bereavement support is for them as well.
And also staff who've lost personal family members.
And staff who have lost
That
personal
can
family members can
participate
participate as well,
in
yes.
such a service.
Yes.
Is there a fee associated with any
No,
of that?
no,
So-
that's just one of our gifts.
And I think that's very important. And I know that's underutilized. I'm sure it's underutilized. And I think people really need to be aware that that type of ongoing support is really available to them, and how important
Yes.
it really is.
It is
because
important.
It is a process, and we all grieve in a very different way. People may need the extra support, some people don't. But you're there to help them through that. So I just wanted to ask you, you've moved to Gardner. You're not a new agency. Brookhaven has been around and doing hospice care for a number of years.
6 years, I think. Brookhaven is a New England-based company. We cover all of Massachusetts, southern New Hampshire, Seacoast area. We've got 5 satellite offices, of which Gardner is our newest.
In this market, do you cover all through Franklin County, all the towns, Worcester
Absolutely.
County, through Franklin County?
Absolutely.
Basically up until the New Hampshire border.
Correct.
So this is your coverage area.
Yes, this is our coverage area.
And how long have you been in Gardner?
3 months.
3 months, okay. So,
But we've been servicing the area for a lot longer. We have a number of hospice patients in this area. Actually, the Gardner office was probably a little bit overdue
I see.
because we've been
Yeah,
working here for a while.
yeah, good. And anything else that anyone should know about hospice that we may not have covered? Any other smaller things or?
Well, again, somebody needs to have a terminal illness to be qualified for hospice, but some of the other things to think about, the patient or the family, are they done with uncomfortable, ineffective treatment? Are they done with repeated emergency room visits?
Oh, that brings the question. I'm glad you said that. If I'm on hospice.
Yes.
And I thought, I'm going to eliminate all treatment. But then a trauma happens. I get up to use the bathroom and I have a fracture. I have to go to the emergency room.
You have to go to the emergency room.
Or I choose to go to the emergency room, get that taken care of.
Yes.
What happens? Do you come off hospice and then go back on? How does that work?
While you're in, if you get admitted to the acute care facility, you will have to come off hospice during that period of time.
Okay. How does that happen? Does a hospice representative come in and you just
There's
sort of revoke?
paperwork. It's a paperwork thing.
Okay. It's nothing cumbersome. People don't have to worry
Nothing
about
cumbersome. And also, people can come off hospice anytime they want. It's not a binding contract by any means. So that's a choice they can make at any time, too.
And I think, too, from my experience in the profession of healthcare, people choose hospice too late.
Too late. Yes. Hospice is really most beneficial the earlier that it's brought in, and in fact least beneficial when death is imminent. And unfortunately, in going back to the myths of hospice, many people think that hospice means imminent death or it means I've given up.
That's right.
And in fact, that's not the case. There are many studies being done about hospice patients that have continued to thrive. Like we talked about managing the nausea and then they start eating and
So people can, I just wanted to clarify, if I like to have hospice, people can, I may actually improve, my health may improve for a very short period of time or for an undefined period of time, I don't know. Where I may actually come off hospice.
You can come off hospice.
Once I'm on hospice doesn't mean I'm on it if I get better.
Correct. We have many graduates from hospice. It doesn't mean that you no longer have a terminal disease, you do. But a lot of times with the symptom management and the better quality of life, less depressed, enjoying your daily activities more, sometimes there comes a point when you no longer meet the qualifications for coverage, and we have to graduate patients.
So how do you know if I meet those qualifications? Is that something your staff or a hospice nurse or is going to come in and do sort of I don't like to use the word assessment, but essentially that's what it is?
It's an assessment. Again, our team meets every 2 weeks as a team. With the medical director, and there are certification periods, and in other words, the first 90 days of certification, and then the patient needs to be reevaluated by the nurse, the doctor. So there are recert periods.
So if I'm at home and you've come in, you've talked to the family, you've met with the patient, we've all agreed that's the path that we want to go down. We enroll in hospice, and you come up with a plan. I would imagine you're involved in what family member is coming when, making sure that the person, primary caregiver, has that support behind them so that there's sort of the shift style care being provided by the family. And what are they doing? Like, what is the family member doing? They're providing what? Medications based on what your
family
nurses
provides
say, how
medications,
to do that, and you
yes.
teach them how to do all of that.
Yes, we provide ongoing education on how to care for that patient throughout the different stages of hospice.
So the family member is actually administering, if the patient themselves can't.
Yes.
Actually administering the medication.
Yes.
So you're going to teach them how to do that.
Yes.
And you're going to teach them how to assess pain maybe, or at least recognize pain.
Signs and symptoms, worsening symptoms, when to call.
That's a good
when
point.
to call the nurse. We do have a nurse on call 24,
yes,
throughout the night, on weekends.
And then that nurse will either determine, they'll ask a series of questions
Correct.
And then determine.
And sometimes a visit's
more.
necessary over the weekend as well.
Okay.
They can determine whether it's something that could be resolved over the phone or whether they need a visit, and always followed up with a second phone call as well.
And your staff can, if they need an increase in medication, if the patient needs an increase in medication, your staff can just tell the family member, go ahead and do it based on this series
Yes.
of questions, so they don't have to wait for another phone call back.
Correct.
They're just going to be able to administer per the instructions. Okay, great. Well, this is a lot of information, but it's important information, and I think people don't access this service quickly enough. Maybe they don't know what it is, they're afraid of it. I think we've cleared up a lot of those, a lot of the misunderstanding around hospice and what it is. People, though, I'm sure are still going to have questions. You at Brookhaven Hospice are available for a phone consultation? If someone wanted to
Absolutely,
call and say
informational
they saw this
interview.
show
Sure.
And wanted
Absolutely.
more information. Our viewers can call 855-820-4801, which is a toll-free number. So again, 855-820-4801. And you have a website, and that's brookhavenhospice.com. Again, brookhavenhospice.com. And feel free to give them a call if you have any questions or concerns or want more information about what hospice is. Debbie Tischler, thank you for joining us today. I think this was a great discussion. And like I said, for more information, call Brookhaven Hospice directly, and also check out more information at the Quabbin Valley Healthcare website at qvhc.com. And as always, thank you for watching.